Welcome to part one of our Microlearning series on the management of chronic lymphocytic leukemia. This is medical oncologist Dr. Neil Love. I met with Dr. Mazyar Shadman from the Fred Hutchinson Cancer Center, University of Washington in Seattle, Washington, for a two-part discussion that can be viewed or listened to in pieces or all together. Today on part one, Dr. Shadman comments on a number of key presentations and publications in the field, beginning with a plenary presentation at the 2025 ASH meeting.
The CLL-17 study by the German CLL study group was abstract number one at ASH, so the plenary accompanied by New England Journal of Medicine paper, long anticipated study for the CLL field. Basically, the study looked at three novel regimens and looked at ibrutinib monotherapy versus venetoclax and obinutuzumab versus ibrutinib plus venetoclax. And the question the study was asking was, with the follow-up that they had for this around 3 years, were fixed duration regimens inferior to the continuous therapy? And the result of the study was that with the follow-up of 3 years, those regimens were non-inferior. So important study in my opinion, in what it didn't show. So if the study showed that even with 3 years of follow-up, the fixed durations would be inferior to ibrutinib, then that would have changed our current thinking of how we treat CLL. But to main degree, this study is a confirmation of what we actually do in practice these days. So we are increasingly using fixed duration therapy, including obinutuzumab, and more recently with the approval of acalabrutinib and venetoclax, we have now 2 fixed duration therapies in U.S. I should mention that for audience outside of the U.S., obviously ibrutinib and venetoclax is approved and is being used in other parts of the world, including in Europe, Australia, and Canada. So that was the main message of the study. The study looked at a number of other questions, including what was the impact of some of the high-risk features, including IGHV's mutational status and P53 or DEL17P status. I would say with the current follow-up, there doesn't seem to be a difference, but we do see a signal that BTK inhibitor containing regimen seems to be resulting in a better efficacy. Now, we all know for a disease like CLL, 3 years of follow-up is very short. So when we discuss treatment options with our patients, we don't usually think about the 3-year follow-up or 3-year endpoint. So it's extremely important for this study and studies like this, and we will have more of these, to kind of wait for the longer follow-up and to see what happens in the high-risk group, again, specifically DEL17P, P53 mutated group, and whether or not fixed duration combos are still non-inferior to monotherapy with a BTK inhibitor with longer follow-up. As expected, we saw a high rate of undetectable MRD with the obinutuzumab arm. We know that adding a monoclonal antibody is effective in providing that UMRD rate. That was followed by venetoclax and ibrutinib arm in terms of the UMRD rate. And again, we don't expect an undetectable MRD with a BTK inhibitor monotherapy, and we saw no UMRD, or zero UMRD rate with ibrutinib monotherapy. I think the other interesting point to just remember is that here we had a significant difference in terms of undetectable MRD rate, but the PFS curves were not different from the statistical standpoint. And with the active discussions about whether or not UMRD is a proxy for PFS, this is an important point to remember, and we can talk more about that. Also important to mention the side effect profile and the fact that when you add or when you use a monoclonal antibody, you see a higher rate of neutropenia. For example, we saw 52% versus lower rate in the other arms. And, infection rates were also high in all groups. But when you look at COVID, for example, again, the rate seems to be higher when we use a monoclonal antibody like obinutuzumab, and that's, again, something that we have observed in the past few years. So overall, CLL17 is an important study. Maybe for our practical point in U.S., we don't use ibrutinib these days. So, that's one point. The question is whether or not using second-generation BTK inhibitors in combination with venetoclax or even new BCL2 inhibitor would result in same outcome. And also, as I mentioned, we do need longer follow-up, and we do need more focus on the high-risk population to see if fixed duration therapy is as effective as monotherapy with a BTK inhibitor, which is considered to be by many the standard of care for patients with del17p or p53 mutation.
So you mentioned the AMPLIFY study, and I was curious about your thoughts about these two papers from the ASH meeting. First, the AMPLIFY study, more data from that in terms of prognostic mutations, and maybe you could just kind of reflect back on the AMPLIFY study. And then this other study, to me, kind of related from MD Anderson, which I thought was very interesting, adding in obinutuzumab to the AMPLIFY type regimen, acalabrutinib, later on. So can you comment on these two papers?
Of course, as a quick kind of reminder of what AMPLIFY study was, this was a 3-arm study that just recently finally led to the approval of acalabrutinib plus venetoclax for first-line CLL. So the study had 3 arms looking at acalabrutinib. The second arm was acalabrutinib and obinutuzumab, and the control arm was FCR or bendamustine rituximab BR. So patients with del17p or p53 were excluded from this study because of that chemotherapy control arm. The study did show that both AV and AVO were superior to chemotherapy. AVO resulted in a better progression-free survival. However, in this study, considering the sites of the study and the timing of the study and lack of vaccination for a majority of the patients, there were significant cases of COVID-19 and infections and even deaths from that. So, and because of that, the improved PFS of AVO arm did not translate to a better survival. So with that in mind, this year we had not a longer follow-up, just kind of looking at some of the prognostic or predictors of response. And the investigators looked at a panel of mutations. And, basically the bottom line is that with novel therapy, AV or AVO, when you look at these mutational profiles, novel arm did better compared to chemotherapy, which is not surprising. I think to me, one of the important findings of the study was that when you look at the patients with unmutated IGHV, having a Notch1 mutation seemed to have a significant impact on the progression-free survival. So now we know that patients with mutated IGHV do well, and in that subgroup, Notch1 status did not seem to have at least clinically significant relevance. But when you look at the unmutated group, the patients with a concurrent mutation of Notch1 did also worse, and that this may have clinical implications in terms of how we decide about the duration of therapy and things like that. So, and again, they reported on some time to next treatment numbers, and as expected, with novel arms, both AV and AVO, that result was more favorable compared to chemotherapy. So in terms of the MD Anderson study, which is a very interesting and important and practical study, kind of looking at the 2 questions in a relatively complicated design, I would say. So the question was, do we benefit from adding obinutuzumab to AV? And if that's true, is it better to add it early or later in patients who need it? And what they basically found was that, yes, if you add obinutuzumab, outcomes are better, but if you add it later, the safety profile is improved. And I think this is important because, number one, you use it if patients show evidence of not achieving a UMRD at the defined period of time, and then those are the patients who most benefit. So when you think about risk-benefit ratio, it kind of justifies using obinutuzumab in those patients. And also the infections, the rate of infection, for example, when you look at the late initiation versus early initiation, the grade 3 infections were more common when you used obinutuzumab earlier. And also the rate of neutropenia was higher when you used obinutuzumab earlier versus later. So I do think this study is an important addition to what we know about doublet versus triplet when it comes to BTKI plus BCL2 plus minus obinutuzumab discussion.
So just to follow up with these two papers, first, I'm kind of curious about where AV is fitting into your non-protocol strategy nowadays. And also, are there and also AVO, and also, are there situations where you are using the sort of MD Anderson delayed obinutuzumab strategy?
So first question, where A plus V fits in my current decision outside of the clinical trial, at least in my experience, most patients, for me, it's probably 70% of my patients are interested in some sort of a fixed duration therapy. So my options today are between ven-obino and acala-ven. And I think there's a lot of benefit of not using an infusional drug, obinutuzumab. It's, the convenience factor, the rate of infections we just saw in a couple of studies, and just not having an intravenous drug is meaningful for many patients. So I am actually increasingly using a Cala plus Ven, and in some cases from the Sequoia study, Zanubrutinib plus Ven. But of course, the FDA-approved combo is a Cala plus Ven. And I use it, and it gives me the flexibility of starting with a BTK inhibitor and then adding venetoclax, not necessarily per amplifier kind of a schedule, which added venetoclax on cycle 3. But in real practice, many of our patients have plans for their life, right? They have scheduled a cruise like 2 months from now, and to bring them back right at 3 months to start venetoclax may not be necessary. So the flexibility that now we have with this regimen to start acalabrutinib, and in the next few months when you're ready, when your risk of TLS is minimum, and when you know that you'll be in town for a month, then I add venetoclax. And I think I've seen this being very effective. So effective meaning that helping patients make a decision. Before AMPLIFY or A plus V, the discussions between monotherapy of BTK inhibitor versus venetoclax obinutuzumab sometimes required multiple visits because patients had to think about it and make a decision. Right now, starting treatment is easy because you can make a decision later, whether or not you add venetoclax to it, or maybe some patients just continue. And to your second question of adding obinutuzumab, I personally don't routinely use obinutuzumab in the combination. I think there is risk and benefit.
So let's move on to these next papers focusing on zanubrutinib, and the first two are actually your papers. We just did a program with Dr. Tam as well, looking at this, and he also was talking about this combination of sonrotoclax and zanubrutinib, which interestingly I see is now part of the about to start Alliance trial. But anyhow, let's talk about these papers.
Of course. So the first paper is the Sequoia RMD. A very brief background. Sequoia was the first-line study that led to the approval of zanubrutinib for first-line. Had a randomized cohort of Zanu versus BR, and then had a monotherapy cohort only for del-17p patients where they just received zanubrutinib. And cohort D was a combination of zanubrutinib and venetoclax. Now, what's important about this study is that it included a significant number of patients with del-17p53. And remember, this is a study, or this is a combo that does not include a CD20 antibody. So the findings from the study are important because we see a high rate of undetectable MRD and high efficacy with this combination. At the same time, we also learned a very important lesson, in my opinion, from this study, that for some patients, including patients with high-risk disease, prolonging therapy helps. So when you go from, let's say, cycle 15 to cycle 27, the rate of undetectable MRD actually goes up in patients with high-risk disease, whether or not you define it by P53 mutation or IGHV mutation. And that, to me, has a very important clinical implication. So what does it mean? If I have a patient who has del-17p and they're interested in fixed duration therapy, and let's say, because this regimen is now actually listed as a category 1 or preferred choice for del-17p frontline. Let's say I start a patient on zanubrutinib and venetoclax, and at the end of 1 year, for example, they still have detectable MRD, and I would continue actually an additional year. Do I follow the MRD guidance that the study provided? Probably not, because it was a pretty complicated criteria. But I think we just use the principles, right? So I think for high-risk patients, this study shows that you do gain benefit from longer treatment, and that's important. And we had a follow-up at ASH that this was originally presented and published last year at JCO, and we had a longer follow-up. I think this is an important combo, and again, for high-risk patients, if you're trying to avoid a CD20 antibody, considering this and thinking of an MRD-guided approach is important. So the second study I wanted to talk about was actually a publication that we just had, and that was an indirect comparison of zanubrutinib versus acala plus venetoclax. And the question is, why are we comparing continuous therapy versus acala-ven, which is a fixed duration? And so the answer is, for many patients, efficacy is the main goal. We just talked about CLL17 study that actually did compare ibrutinib, a continuous therapy, versus 2 fixed duration regimens, and in a randomized control study. So the question is relevant. And we also discussed that with CLL17 study, despite the fact that it's an extremely important study, may not be very relevant these days because ibrutinib is no longer used. So the question we're trying to ask was, what if we compared zanubrutinib in first line with the acala plus ven? The issue is that on the Sequoia trial, patients were older in general and less fit. AMPLIFY selected more fit patients because of the chemotherapy arms that were there, and FCR was part of it. So what we did here, we did an indirect comparison, and we used two methods. One by kind of restriction and kind of because we have access to the patient level data from the Sequoia study, we did some restriction of the zanubrutinib cohort. Then there was also a component of matching indirect comparison between the two. And, we showed what is not surprising. We already know that, or I guess the hypothesis was that if you continue an effective and well-tolerated drug, your efficacy is probably going to be better. So what we showed here was that in terms of efficacy, and if efficacy is the focus, zanubrutinib monotherapy was superior to acala plus ven. Now, is that the only factor that patients consider when they decide about treatment? No. There are patients who, when you discuss these results, they understand that by going with a fixed duration therapy, they may gain a few shorter months of remission or maybe a couple of years, but they still value the fact that they can be off treatment for 3, 4, 5, 6 years. So I think this study just adds another piece to the conversations we had with patients. And for those who really focus on efficacy, I think this study provides an important, I would say, practice guiding information. Another study we saw at ASH, which is important from a number of standpoints. Number one, it is kind of introducing a new combination to the CLL field, which is zanubrutinib, which is a known drug, but sonrotoclax is a new BCL2 inhibitor, currently not approved for any indications. And this study is something, the phase 1/1b study that we have been reporting the results in the past few years. And now it is to the point that everybody is excited about the level of efficacy and the depth of remissions we see with this combination. The study uses zanubrutinib first, and then sonrotoclax is added later. And because this was a phase 1 study, 2 different doses of sonrotoclax were tested, and 320 milligram ended up being the dose that we are moving forward. The expected side effects, including neutropenia, were seen in this study. What's really important is the high response rates of more than 50% of patients achieving a CR, but also undetectable MRD rate of in the range of 90%, which is, when you think about it, and we're not supposed to be comparing cross trials, but really that UMRD rate with other BTKI plus BCL2s are in the range of 40 to 50%. And here you have the range of 80, 90%. So we have to wait for randomized trials, but that gives you a pretty strong hypothesis that this combination may be the combination that will be a choice for us. I should mention that there are 2 head-to-head global FDA registration studies that are using this combination. One was the Celestial study, which finished enrollment. The study compares sonrotoclax zanubrutinib versus venetoclax obinutuzumab. The study enrolled super quickly, and we're waiting for the results, which will take a few years probably to see the PFS results. And there is a Celestial 2 study, and that study is comparing sonrotoclax zanubrutinib versus acalabrutinib. So doublet oral versus doublet oral, and I think that's another important study to watch for.
So just a quick follow-up question to your paper there, comparing Sequoia and AMPLIFY. I can imagine, anytime people present indirect comparison, there's a certain number of people's blood pressure goes up and gets all upset about it. I'm curious what kind of reaction you've gotten to this.
So I've been involved, and I should be blamed for a number of these studies, I think as long as we know the value of this type of studies and where they stand in terms of our evidence-based medicine hierarchy, this can be helpful. These analyses would never replace randomized trials, but we all know that with the pace of drug development, it's impossible to have head-to-head trials for all kinds of combinations. I use these, even myself, we did a number of indirect comparisons between Zanu, Acala, and now with this.
Right.
I just use them as a part of my discussion, right? So the discussion has to focus on head-to-head randomized trials. But as I said, if a patient asks me, you're telling me I can go on Acala-Ven, you're also telling me I can go on Zanubrutinib, everything you told me, I have a strong support. I want my cancer to be in remission for the longest period of time. Which one should I go with? I can guess and say, probably Zanubrutinib, or I can refer to a paper like this and say, hey, we looked at this and there seems to be a trend. So I guess as long as we know where we're using it and what's the value, I think it helps the clinical practice.
Yeah, I think that's a great point. I just hope everybody does sort of have that understanding. I think probably a lot of people do. This concludes part 1 of our series. Special thanks to Dr. Shadman, and thank you for tuning in. This is Dr. Neil Love for our CLL Microlearning series. Stay tuned for part 2, where Dr. Shadman reviews a series of cases.